So it's a real pleasure to be here. It's great to see such a packed room. It's been a very pancreas-filled day with topics going on, discussions going on really all day. Great presentation by David Kupi that just finished, and some interesting discussions on this topic earlier. So it's really a pleasure to have a chance to debate one of our colleagues from Heidelberg. I'm old enough to remember some very interesting debates going on at the Pancreas Club between Marcus and my good friend Charlie Yeo. And I don't think you can find two more competitive people than those two. And I would say it never quite came down to a fist fight, but it got close a couple times. But I promise those of you who look to see a MMA battle here, Thilo and I have sort of sorted this out that it won't work. When it came to the time that we were debating, I was a little unclear what the topic was going to be. Heidelberg has made so many great advances. They're such a well-known and well-respected pancreatic sensor. I didn't know what we were going to be debating. Clearly, the management of chronic pancreatitis, there are strong feelings coming from Heidelberg on those techniques. The management of side branch IPMMs have been debated back and forth on many fronts. And certainly, as we've heard, there is certainly an aggressive attitude towards the management of pancreatic cancer. But in order to show the agreement, we came up with a couple of ground rules. The first of all, it would be the discussion of the role of neoadjuvant therapy for borderline pancreatic cancer. And I'll put the question resectable pancreatic cancer there. I did this before I knew what Dr. Cameron was going to say today, but we'll talk about that a little bit later as well. And we were both in agreement that there is certainly a role for neoadjuvant therapy for locally advanced pancreatic cancer. Now, I would say that the tour de force of beautiful surgical operations and dissections and reconstructions that Thilo just showed, I will not match in any way. I'm going to focus mostly on institutional data, simply because, as was pointed out, we don't have large prospective randomized trials yet. We're all anxiously awaiting the further trials that are out there. So again, I will apologize for the level of evidence that I'm providing. It's both mostly a single institution. So neoadjuvant therapy, what are the arguments for it? Well, first of all, it selects patients who recur early. It eliminates those patients who have progressive disease. It ensures the patients get treated. As we've heard multiple times, including on one of the best of the best sessions today, in the United States, only a minority of patients go on and get their adjuvant therapy because of many times complications or just simply giving up after a complicated course after pancreaticoduodenectomy. And I think the evidence is strong that neoadjuvant therapy does increase your probability of having an R0 resection. However, the arguments against are substantive too. There is no proof that it improves survival. And secondly, it may eliminate the window of opportunity in some patients. I think the game changer has been, however, the recognition of the importance of R0 resection. And Thilo showed some great data to make the same point, that if you can get an R0 resection, it really makes a difference. And anything that's even close or certainly a true R1 resection, the benefit of your surgical therapy is eliminated. So our goal really is to take patients and get a higher chance of having a true R0 resection. So what really changed the attitude? Because I was clearly in the camp that there was no role for routine neoadjuvant therapy in pancreatic cancer patients. I've been in debates with Doug Evans and people from Memorial for decades on this topic. And what really I think was the game changer is we finally started seeing some better chemotherapy regimens. And this study, which was in stage 4 pancreatic cancer, really showed the advantage of the FOLFIRINOX method. And when this paper was published in 2011, it made a lot of us think, if they can show this level of success with stage 4 disease, what might we be able to do with patients with locally advanced or borderline resectable disease? And these terms are very being able to be intermingled quite a bit. And although I was on that consensus that provided the definitions, there clearly are it's stages of gray between borderline and locally advanced. And many times you're not able to predict, and certainly after neoadjuvant therapy, as Thilo has said, all bets are off. You really can't tell what is really viable tumor that is existing. So in our field, program, and I'll show you data later. And in my minds, we really don't make much of a distinction between borderline and locally advanced. We treat them essentially all the same. So our data will be a mixture of both borderline and locally advanced, which I think does strengthen our argument. So this is a case, actually, and again, it's a case that started this progress at the MGH in about 2011. We'd heard about the FOLFIRINOX results. This was a 41-year-old female, someone no one would ever want to give up on, had a 3.6 centimeter uncinate tumor involving the superior mesenteric artery, and had a CA19-9 in the range of about 1,000. She received 4 months of FOLFIRINOX therapy and 50 gray of chemoradiation. Her CA19-9 dropped dramatically. Now, I hope this is able to be seen, but you can still certainly make an argument that there's concern about tumor on the undersurface of the SMA. Maybe there's a fat window around the SMV now, but this case would certainly be still concerning as if there was still viable tumor. But yet one of my colleagues was aggressive, took this young lady to the operating room, and we're proud to say that really still 7 years later, she is still a survivor from her tumor. Her final path was a 1.6 centimeter T2 N0 negative margin resection. So this prompted a trial. My partner, who probably could have done a better job and certainly would have been better looking than me up here, Christina Ferroni, has really led this presentations and the work that's been done at our institution. I'm going to summarize a number of studies that have come through, originating with the first presentation in January at the SSO in 2014 and published in Annals in 2015. This is our most recent update on this data. It looks at what happens with CA19-9 and tumor size pre and post FOLFIRINOX. This includes only patients with locally advanced or borderline resectable. And as you can see in the pre-FOLFIRINOX treatment, every parameter has fallen in the post-treatment. So dramatic effects both in terms of size and CA19-9. What about the results in clinical versus operative results? And here again, non-randomized data, but 155 patients who in our multidisciplinary conference were considered to be upfront resectable, stage 1 or stage 2, certainly not locally advanced, whereas the patients who were entered into the trials related to FOLFIRINOX were all at least borderline, if not locally advanced. And again, this is the information that you can see that these operations are more challenging, they're longer, there's more blood loss associated with them, but ultimately in terms of no difference in terms of the patients, in terms of their age, the FOLFIRINOX patients tended to be a little bit younger, but in general, we can see that the comparable surgical results, although more challenging. Well, what about the postoperative results? Here again, you would have thought that these patients who had locally advanced cancers, longer operations, more blood loss, the results would potentially be worse. But yet there was no difference in terms of the overall complication rate and severe complications. The readmission rate was favorable for those patients who received FOLFIRINOX. Length of stay was favorable in that group, and the overall postoperative mortality was essentially identical. So you can do these operations safely after these therapies. There were, of course, some in both groups that had vascular resections. How about the pathologic results? Again, remember, non-randomized trial, but basically the no neoadjuvant therapy, 155 patients are patients who were considered upfront resectable versus the 128. So we have smaller tumor sizes, we have a lower incidence of positive nodes, a greater likelihood of a negative margin, and less lymphatic invasion and less perineural invasion. Encouraging results for worse looking tumors to begin with. And of course, the money lies with the survival analysis. This is the survival from the time of diagnosis. Of course, you keep that into consideration that those patients with FOLFIRINOX had at least 6 months, if not longer, of treatment, but still a significant advantage. And if you look at the overall disease-free survival from operation, again, significant improvement in the patients with the more locally advanced, more borderline tumors, but yet after neoadjuvant therapy, their survival is improved. Now, everybody says, well, is this just the FOLFIRINOX? Is the resection adding anything? So in the course, we've had 159 patients, of which 31 were not resected. And as you can see, clearly resection does add to the benefit for these patients. So it's not just that the chemotherapy and radiation is extending their life, it's that combination with surgery. This is, I think, an important trial, or results of two different trials that we had, one for patients who we at least classified initially as borderline, those locally advanced. If you can see, they really are totally indistinguishable. Those patients who were classified as locally advanced, 49 patients, 69% were resectable, 61% had an R0 resection. In those that we considered borderline resectable up front, 67% were resected and 65% had R0 resection margins. So really, the mystique between borderline and locally advanced really is not as important. We do have one other club in our bag for our Scottish moderator here. This is intraoperative radiation therapy. This has existed. I was not a believer in IORT before I came to the MGH. Still not sure I am, but it is a technique that we do call upon. It gives you the opportunity, if you're worried about a margin, if you're worried that there was cancer there at one time and isn't there now, this is again, no evidence, one-level data in any way, but it certainly shows some advantage of IORT in the neoadjuvant era. We're even more excited about the happenstance finding that the drug losartan, which people take for hypertension, is also very positive effect on the results of chemoradiation. This is a trial that's soon to be published in the Journal of Clinical Oncology. 50 patients who had completed treatment, 88% underwent R0 resection, and the survival data, again, both in terms of overall survival and disease progression-free survival is extraordinarily strong. So we're going to get better. The drugs are going to get better. Combination of drugs, adding immunotherapy can offer us some more exciting news. But as Dr. Cameron mentioned, without any data today, what we really are happy with and surprised and excited about is those patients that are complete responders. Now, this is one of the 9 patients in our original series who had less than 1 millimeter of residual tumor. But there are, as in the Hopkins experience, which was just published in the July issue of Annals of Surgery, about close to 200 patients, 10% of their patients had total complete responses. And if you can see from these results, their overall survival for this population is greater than 60 months, with really a very strong predictive value of the neoadjuvant therapy leading to the complete pathologic response. So again, we're getting to a point where we're excited about these results and the hope that they can make a definitive step in advancing disease for locally advanced and borderline patients. So my conclusions, I think you can tell that we think the chemotherapy has gotten better for resectable patients. The surgery has improved, but now really where we're trying to go is from just getting the tumors out with great surgical results, doing a better job of extending this therapy to those patients who may have been denied these therapies for locally advanced or borderline resectable disease in the past. And who knows, the next question will be answered, and certainly our colleagues in Heidelberg have already raised the question is, what is the role in those patients with metastatic disease? I've been fortunate to be in these debates on multiple occasions, usually assigned the losing argument. Most recently was in March of 2016 at the SSO. I debated Doug Evans on the role of neoadjuvant therapy for upfront resectable pancreatic cancers. And in that sophisticated group of surgical oncologists, I felt like I was Daniel being fed to the lions, but Doug beat me up pretty bad on that. But I was a little surprised today to hear John say that in his opinion that he would certainly see that in the future, neoadjuvant therapy is going to be part of the treatment of all patients with pancreatic cancer. I had the opportunity a couple years ago in celebrating a significant anniversary to take a boat cruise up the Rhine and had an opportunity to spend some time in Heidelberg. What a beautiful city. What a city that has made such great contributions to the management of pancreatic cancer. It's an honor to try to challenge some of the tenets in which they practice. And again, we do well in Boston, but we certainly hold this group in high respect. So thank you very much for the opportunity to present the con argument.
Excellent. 2 fantastic presentations. What I'm keen to get is some audience participation. So please do come to the microphones and do set them a few challenges. And it's very difficult to see. Is anybody at a microphone? Wave your hand. If not, can I start? Keith, so Thelio presented cases that radiologically looked locally advanced, not resectable, but used the term if giving neoadjuvant and they stayed radiologically stable, they'd go in, explore, do frozen sections, and if they were negative, proceed. Would that be your approach?
Yes, we don't expect to see these changes go away radiologically. They just don't. I know my colleagues at MD Anderson haven't quite drank that Kool-Aid yet, but I think the rest of us have accepted the fact that just because there's changes around the arteries and veins doesn't mean there's still cancer there. We do like to see the CA19-9 go down. If the CA19-9 in a patient who was not jaundiced started out at 1,000 and it goes down to 30, or after their jaundice is resolved, it was in the 600-700 level and it goes down to double digits. So we're excited about that because we think that's a biologic representation. And the patients actually tolerate it pretty well. I'm not sure that 103-year-old that we saw earlier today would have been a candidate, but certainly we pushed it into patients with the 70s and 80s. And it really isn't a lot of downside for trying it. So we follow the same view that we don't let the radiology changes discourage us unless it's progressed or unless it's there's certain areas, particularly where you start seeing the branches of the SMV, where it's just not reconstructable. That's the area that we will tend to back off. And we've learned that from essentially the experience of getting in there, thinking we could get it out, and then deciding we just couldn't sacrifice any venous tissue to do the reconstruction.
Okay, Dr. Helton.
I'd like to hear the opposing sides about the merits of doing radical surgery in the presence of metastatic disease.
Okay, Thilo, you mentioned that in your talk. You start off. Yes or no?
I didn't mention it because it was more, it did take too much time. But of course, we have metastatic patients, about 37% in our series with FOLFIRINOX, and we resected them. Some of them also with metastasis resection. And I think this is, of course, off limits in some way, but we do it from time to time without a clear stratification. Unless we have more than 5 metastases, we would not do that. If these are stable under FOLFIRINOX, a young patient, we would try. But the criteria are, of course, not clearly defined at the moment.
Keith, any further comments?
We're leaning that way. We've had an occasional patient that the metastatic disease has disappeared. I mean, most patients now, whether they're resectable or they're going down the track towards resection or not, will start out with FOLFIRINOX treatment. That's the first line. And if the number of metastases are small, if there is a response, so we have one patient that I did had a disappearing metastasis. We ended up taking that patient to the theater and doing a very favorable pathologic resection. Unfortunately, 6 months later, the lesion recurred, but the patient's still alive now a year and a half later, receiving further chemotherapy. We just sat down with our oncologist, our radiation therapists, and are entertaining a protocol where we would resect favorable candidate patients who do not progress with disease with 4 or less metastatic lesions.
Okay, Dr. Radanovic.
Thank you for a nice presentation. My question for Kit. Kit, if you have locally advanced tumor, after the FOLFIRINOX, it stays stable, there is no changes on CT, whether you're going to resection or no?
I think the question is if it's locally advanced and have completed our full course of therapy, and certainly if the CA19-9 has gone down. I mean, if the CA19-9 still stays at 1,000, or if that's going the wrong direction, we would perhaps back off. But I would say that if we don't see progression or development of metastatic disease for locally advanced, we will consider those patients, taking them to the OR. The one benefit that, again, I mentioned, and I have no stock in the machine or the company, but in many times we do that knowing that we do offer the opportunity for IORT for those patients to give them a boost if we do end up with a R1 margin, or in some cases, Carlos will even do IORT for unresectable lesions. So that's a little bit of a card that we have in our hand to pull out.
Thank you.
Thilo, anything to add?
No, I just wanted to ask Keith, what is, from your experience, the percentage of patients that drop out under FOLFIRINOX, which are clearly progressive, in your institution, how many % of the patients will never go to surgery?
So in that slide that I showed, it was roughly a third of the patients who were started under those protocols did not go to surgery. Or were not resected, I'm sorry.
Were not resected.
67%, 68% were the percentage that were resected, and the R0 resection rates were in the 60% either. So and I can't tell of that one-third how many actually were taken to surgery and not resectable versus didn't get to surgery at all.
And the Heidelberg experience, is that similar?
From our experience, it's about 15% of the patients who clearly progress, and the remaining 85% you take to the OR, and then you can resect about 50 to 60% of those.
Yeah. So that data that I have is not randomized, but it is prospective. So everyone who's gone into these trials has been entered in a clinical phase 2 trial, and so the 68, 67% is true prospective data.
Okay, so some more questions, please.
Am I able to ask a question over there as well? Hello. Hello.
Different place, okay.
Sorry, over there, is that Merv?
Thank you. No, it's Thomas Grimmer from Vienna.
Okay, please.
Keith, may I just ask you to clarify a bit more what is the role of the chemotherapy, so FOLFIRINOX, and then radiotherapy in every patient? I know you have data of limited radiotherapy in patients where you have already a response on imaging. So can you clarify a bit who gets radiotherapy and for how long?
So essentially, we go with 8 cycles of FOLFIRINOX, which is roughly every 2 weeks, 8 cycles, so 4 months of chemotherapy up front. We then restage the patients and begin external beam radiation therapy. Typically, it's in most of the data that we've had, it's been standard external beam photon therapy. We now are using SBRT in some of those patients. In some of the patients who've had even more dramatic response, we've tried proton beam therapy. Although the advantage of proton beam and SBRT, it shortens the window in which you can take the patients to the operating room. But generally, the results I showed for most of those patients are 5 weeks of external beam radiation therapy or 50 centigrade. Then we wait, and we wait somewhere around 4 to 6 weeks. We restage them at about 4 weeks after the completion of the radiation. If the disease has not progressed, it's not metastasized, the patients are now starting to feel good, we schedule them for surgery within the next 2 to 3 weeks, operating on them in the interval about 6 to 8 weeks after completion of the radiation therapy, and shorter for the SBRT. We have, as a referral pattern and a place that's now starting to get known for taking on patients who other people won't take on because of our belief that, as in Heidelberg, that everybody deserves a chance unless the disease has progressed. The last Whipple I did in this case was 4.5 months after SBRT, and there was an old line that Dr. Cameron used to say, if it's not cancer, it's something worse. I mean, that was just the toughest dissection, 5 months after SBRT, but it turned out it wasn't cancer. And this patient had a near complete response, and all margins were negative, despite the fact that both the SMV portal vein and part of the SMA had changes that were worrisome radiologically, and to some extent worrisome even at surgery.
Okay, let's try and get a couple more questions.
Okay.
Apologies, I'm missing somebody, but there's folk in the middle here.
Isaji, my name is Isaji Mie, University of Japan. I'm asking to the Professor Hackard. Your approach to the triangular approach is very nice. I did the same approach, but if you to achieve that triangular approach, usually we cut the splenic vein, confluence of the SMAV and splenic vein is, I think, is removed. So in such cases, we sometimes experience left-sided portal hypertension. How about your opinion?
In regular, you have a total pancreatectomy in these patients, and then usually you don't have that problem because in most of the patients you also have to cut the stomach quite high, a 2/3 resection or something like that. And I think then you will not experience that problem. You can, if you do this for some way, taking away the splenic vein on the portal vein confluence and preserving the spleen, you may insert it on the renal vein, for example, the splenic vein. But this is rarely needed in cancer patients, from my experience.
Okay. I would say that our first line before we would put a graft in is to sacrifice the splenic vein without doing total pancreatectomy, and we have not seen any incidents of left-sided portal hypertension, certainly no bleeding.
In my opinion, it's Japanese multi-center studies, about 20 or 30% of the patients developed left-side portal hypertension, and also some patients developed bleeding, portal vein related bleeding. So we usually perform the splenic artery ligation or cut, or splenic vein to the renal vein anastomosis.
Okay, thank you. Keith, two parts to the question. Arterial resection, yes or no? If yes, total pancreatectomy, yes or no?
So I think we're believers in the hepatic artery resection and reconstruction. It's a lot easier technically. We would be in favor of that in a Whipple procedure. We've done a few Applebys, not to the extent that they've done in Heidelberg or some of the others. So that form of arterial resection, hepatic artery resection, I really hesitate to talk about resection of the SMA, both the consequences, and the other thing, Thilo pointed out, the quality of life after their patients. Patients after SMA resection really do have a lot of GI diarrhea complaints, and I think it's more interruption of the nerves and things along that line. So it'd be very unlikely at our institution that someone would get an SMA resection.
Okay, last question. I think time will be done. Thank you.
My name is Stefan Stettner from Innsbruck in Austria. So I've experienced the same, and I think if the back pain has resolved, it's also a very good sign that there's good response. So my question is practical. If you take 3 frozen sections during the operation and one comes back as positive, would you stop the operation? And if not, what is the outcome of these patients, and would you recommend radiation afterwards?
Thilo, do you want to take that?
Yes, I mean, this is an individual decision, of course. If you have 3 negative frozen sections, clear, go on. If you have 1 positive, you have to decide either to take away an artery. I mean, this is possible even after neoadjuvant therapy. You don't always have to spare the arteries in selected patients, of course. Or you say, yes, I do an R1, but we nearly never do a postoperative radiation. Yeah? Our radiotherapists don't like that, and we are not convinced that this is beneficial.
So let me just clarify. I hate to drag things on. So your neoadjuvant protocol is chemotherapy only, no radiation. So our patients have already had their radiation up front. If we have a positive biopsy, 1 positive biopsy in the vein, if it's, again, in the part of the vein that can be resected and reconstructed, we will do that. We will not stop. If we have a positive margin on the SMA, we will not resect. We will probably complete the resection, and we would add IORT.
Okay, thank you.
Okay, ladies and gentlemen, we've heard from 2 giants in pancreatic surgery. I trust you'll give them a round of applause, and we'll close the session. Thank you.